Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we will be covering highlights from the recent World Conference on Lung Cancer, which we attended live in Barcelona. To begin, with John Varlotto from Marshall University in West Virginia, who will go through findings from a phase 3 trial of concurrent and consolidative durvalumab versus consolidation durvalumab alone for unresectable stage 3 non-small cell lung cancer.
It's a great honor to present at our presidential symposium here at the IASLC meeting. I presented ECOG-ACRIN EA5181, which really was looking at trying to improve outcomes with locally advanced unresectable stage 3 non-small cell lung cancer. This trial basically looked at randomizing patients to chemoradiation therapy or chemoradiation with concomitant durvalumab. And both arms were followed by consolidative durvalumab, which was proven by the Pacific trial. So both arms, if you did not progress, did not experience pneumonitis, and had toxicities of grade 2 or less within 45 days, you could proceed to consolidative durvalumab. It should be noted that during the concurrent phase, we gave 750 milligrams every 2 weeks. Consolidation was 1,500 milligrams every month for up to 12 months. Yes, the primary endpoint with EA5181 was looking at improving overall survival compared to the Pacific regimen, was as chemoradiation therapy followed by consolidated durvalumab. We were looking at improving survival by also giving the addition of concomitant durvalumab during the course of chemoradiation therapy. Our secondary endpoints included progression-free survival, recurrence rates, overall response rates, and also toxicity. And those are the secondary endpoints that we looked at.
Next up, with Alessio Cortellini from Italy, he discusses the highly anticipated abstracts presented at the first presidential symposium, including FLAURA2, ACROSS2, and HARMONi in EGFR-positive non-small cell lung cancer.
This morning, a few abstracts has been presented. I'm super excited, honestly. The most important ones places themselves in the larger scenario of the evolution of the treatment landscape of VEGFR positive disease. We saw the positive survival updates of the FLAURA2 trial investigating the combination of osimertinib plus chemo against osimertinib alone, and it was positive, complementing the earlier PFS data. And then we saw the update of the ACROSS trial investigating aumolertinib, another third-gen TKI plus chemotherapy. And again, this update was positive, therefore broadening the evidence around the utility of combining chemo to a backbone of single-agent third-gen TKI. And then we also saw the broader results of the HARMONi trial investigating bispecific ivonescimab, a bispecific targeting VEGF and PD-1 combined to the standard chemotherapy against chemotherapy with positive results in the post-progression setting, expanding the post-progression toolkit for patient progression. So, general reasoning around this topic is that now we have 3 clear framework for first-line treatment: osimertinib alone, osimertinib plus chemo, and amivantamab lazertinib. We are sort of spoiled by options. It can be a bit complex, but it's a good problem to have at the end of the day, because we're moving from the one-size-fits-all to a more personalized approach. Therefore, it's just more ways to have a more personalized care. So it is time now to onboard patients in the decision-making process right from the beginning and making decisions shared, weighing pros and cons, weighing disease control, the expected toxicity profile, logistic, patients' priorities, and all that. It's great to have this complexity.
He also discusses findings from the 2 analyses of the Pembro-REAL-5Y registry evaluating long-term survival in patients with advanced non-small cell lung cancer treated with first-line pembrolizumab.
Both of these abstracts are 2 analyses of the same registry, which we called a Pembro-REAL-5Y registry. It's a registry involving patients with advanced stage NSCLC and high PD-L1 expression treated with pembrolizumab outside of trials. What makes the registry unique is that we have more than 1,000 patients from 61 institutions across 14 countries. Therefore, it's a global registry and a 5 years follow-up. It's even longer than 5 years. So it allows us to explore long-term outcomes in the real world. We also curated in this registry a quite broad panel of variables, almost 40, that goes beyond common oncological features. So comorbidities, concomitant medication, and other health markers. We already presented the general results, reporting very good survival figures. 1 out of 4 patients is alive at 5 years. But what's interesting is that when you have all of these variables that are potentially associated with one another, you have a problem with conventional statistics because these variables can be collinear. And also, when you have these long-term follow-up figures, conventional statistics may struggle in capturing evolving trends of variable over time, and now they have a role in shaping the risk of death as follow-up matures. Therefore, we applied a novel AI algorithm called NAIM that has been developed at my institution by our engineering department, the University Campus Bio-Medico in Rome, that is great in dealing with collinearity and evolving trends. In these 2 abstracts, we specifically focused in 2 frail populations, patients with poor performance status and very old elderly patients. And we did a similar analysis. In patients with poor performance status, we found that surprisingly, 30% of them were alive by year 5, and it's not negligible to consider the overall poor prognosis of these patients. And with AI, we found that no single variables was able to depict and understand who these long-term survivors were, but rather it was a mixture of variables. While in the age-based analysis, we found that when AI dealt with all the comorbidities and concomitant medication, basically age was not a factor that was able to impact survival. Lastly, an important point is that we found that over time, the common oncological features were the most important drivers of early mortality within the first year, but then by year 2 and year 5, health markers like the lack of hypertension, cardiovascular comorbidity, and BMI regain importance. So the message is dual, that prognosis is, more complex than single ECOG-PS or age can depict. And also in the modern day oncology, where we have long-term survivals, we need to get back to a more holistic approach in taking care of comorbidities in long-term survivals.
Following on, Anna Baramidze from Tbilisi comments on 5-year results from the Empower Lung 3 trial of cemiplimab plus chemotherapy in untreated advanced non-small cell lung cancer.
So Empower Lung 3 Part 2 is a randomized, double-blind, placebo-controlled phase 3 study where patients with non-small cell lung cancer without actionable genomic mutations, regardless of PD-L1 expression level of histology, were randomized 2:1 to cemiplimab or placebo for plus 4 cycles of chemotherapy. And we presented in WCLC 5-year outcomes of the data, and we had really good results related to the overall survival. So 21.1% of overall survival we got with the patients who have been treated with cemiplimab plus placebo versus 12.9 months. And it's an overall survival, and the hazard ratio was 0.662. And also we have very favorable objective response rate. Cemiplimab plus chemotherapy favored 44% objective response versus 22% with the chemotherapy. And the PFS is also 8.2 months versus 5.5 months. So in overall, just in all aspects, the cemiplimab plus chemotherapy favored chemotherapy alone.
Next up, Nicolas Girard from Paris discusses findings from the PAMELA-2 trial of subcutaneous amivantamab administered every 4 weeks plus lazertinib in first-line EGFR-mutated non-small cell lung cancer.
So this is PALOMA-2 study, multi-cohort study. Here, this is a cohort of patients first-line, common EGFR mutation, receiving amivantamab plus lazertinib, as we see in the landmark Mariposa trial. Mariposa has just been published in the New England Journal of Medicine, showing the benefit of the combination versus osimertinib. how to move forward and integrate amivantamab subcutaneous in this regimen. This is the PALOMA-2 cohort with amivantamab every 4 weeks, subcutaneous formulation, and in combination with lazertinib, integrating the VTE prophylaxis for the first 4 months, and also looking at the outcomes of patients. Exposure to amivantamab was actually similar as expected with the subcutaneous formulation. We have in this cohort of patients a response rate of 83%, very similar to that reported in Mariposa. We see prolonged responses in those patients, median not yet reached, so no duration of response yet, no PFS, no OS. In terms of safety, we see a very low risk of VTE, less than 10%, so in line with what is expected in this patient population. With the subcutaneous formulation of amivantamab, we see a very low risk of infusion-related reaction, as expected. In this cohort, the cocoon regimen was not implemented for the dermatologic prophylactic management, and we still see some cutaneous adverse events, again, as expected. So this data really shows the value of the subcutaneous formulation of amivantamab, which will be very helpful for the patients, very helpful for the patient care organization at the hospital, and support, obviously, the Mariposa regimen as the standard of care for the patients with EGFR common metastatic EGFR common mutation non-small cell lung cancer.
Professor Girard also goes through various mesothelioma trials presented at this year's World Lung.
Mesothelioma is one of the rare thoracic cancers. Standard of care for patients with advanced disease is either combined immunotherapy with nivolumab plus ipilimumab or combination of chemo plus pembrolizumab. We have landmark trials that demonstrated the benefit of immunotherapy as compared to chemotherapy. Several abstracts presented looking at biomarkers. And which are the biomarkers in mesothelioma? These are mostly based on mutation in some key genes, including BAP1, TP53, NF2, MTAP. And we have new data coming from large databases, such as the IASLC database, looking at the prognostic value of these alterations. For example, this is the first time that we have in a large cohort correlation between BAP1 immunohistochemistry and BAP1 using NGS panel. Pretty good correlation. Also, the prognostic value of BAP1 loss associated with a better outcome in mesothelioma patient, more frequent in the epithelioid histologic subtype. Also, some data, very nice data looking at resectable mesothelioma with neoadjuvant nivolumab plus ipilimumab. Nice data showing the value of circulating free DNA to predict the chance of surgery in those patients. So quite good correlation with between ctDNA clearance and the chance of surgery and the survival outcome. So maybe a potential tool for the future and to better select the patient for surgery. Also very nice data, again, in a trial for resectable mesothelioma, looking at single cell signatures and again, to better understand the correlation between the tumor microenvironment landscape and the mutation profile. So again, very nice data looking at these aspects. The other point and the key question in mesothelioma is whether we should integrate the assessment of these biomarker in the real life, not only for the diagnosis, but also for the assessment of the prognosis, the stratification of patients, and the prediction of the efficacy of therapies. So very important to continue to work on these aspects in mesothelioma.
Finally, we have Kenneth O'Byrne, who provides us highlights in small cell lung cancer, including trials that assessed tarlatamab-based combinations in this setting.
I think for me, the most interesting data I've seen for small cell extensive stage is the combination of tarlatamab with atezo and tarlatamab with durvalumab, because the two standard treatments that we use at the moment in the first line setting. And that data looks very promising. You know, we're seeing very long progression-free survivals of magnitude we've never seen previously. Will that translate into real benefits for patients in randomized controlled trials? We don't know, because phase 2 type trials often select really good patients. So will this translate? We'll have to wait and see. But that was very, very encouraging. And I think also the lurba and extidine data that was presented previously, there's a possibility in some patients of moving that into the first line setting, particularly in limited stage small cell. Can we move tarlatamab into limited stage small cell lung cancer? Some of the antibody drug conjugates look great. The tri-specific antibodies look great. It's all very encouraging, that we're going to have better effective treatments, that we might lengthen people's lives. We might cure some patients that we couldn't cure before. And in limited stage disease, we might really make massive impacts.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.